informant is he himself and he's reliable. The patient complained of fever since 1 month, fatigue since 1 month, and rapid rise in creatinine since the past 15 days. I'm coming to the history of present illness. The patient was apparently well 1 month back when he started having fever. The fever was low grade in nature, non-documented, not associated with chills or rigor, and responding to paracetamol medication. There was no history of any burning, micturition, cough, hemoptysis, headache during this time. No history of polyuria, frothy urine, hematuria during this episode. No history of loose stools or vomiting either. Patient patient complained of fatigue during this phase, which was initially more during early morning, and he initially thought it to be work related, but later it became severe, so much so that he had problems in getting out of bed and doing his routine activity. The patient initially tried to manage these symptoms at home, but later he went to a doctor and had to be evaluated for the same. His blood pressure, sugar, and other blood tests were done. Blood pressure was told to be normal, sugar to be controlled. Routine blood and urine examination were done, and he was told that his renal function has deteriorated since with a baseline report 6 months back, which showed normal creatinine levels, which has increased now, and his hemoglobin has also fallen as compared to the previous value. He was prescribed some medications for fever and these symptoms, but he did not respond well, and so a follow-up visit in the next 3 days was done and repeat investigations were done. Repeat investigation showed a further worsening in hemoglobin levels and creatinine levels. He was later referred to our hospital for further management. The hemoglobin which the patient tells was around in the range of 12, 13, around 1 month back, which reduced to 10 days back, and it was now 6.5. Creatinine, which was initially 0.9, had increased to 2.5 and up to 5.2 at this time. There was no history of any cough or hemoptysis during this time, no history of melena or hematemesis or any bleeding episode from elsewhere, no history of hematuria, graveluria, frothuria, no history of nocturia, polyuria, or any symptoms suggesting lower urinary tract symptoms. There was no history of any reduced urine output, no history of sore throat or cola-colored urine, no history of hair loss, oral or genital ulcers, no history of nasal deformity, nasal crusting, or any symptoms from ear, nose, throat point of view. No history of joint pain, swelling, or any other problems. Patient also gives history of breathlessness on exertion since the past 1 week, when he initially did not have problems in going to the washroom, but now he feels breathless when he goes to the washroom. There is no history of swelling over feet during this time, no history of orthopnea or paroxysmal nocturnal dyspnea, no history of palpitation or chest pain. So this is my present illness.
You can continue.
So past history, patient was diagnosed as diabetes mellitus 4 years back during a routine clinical evaluation. He was started on oral, he was given a complete blood workup was done, and he was started on oral hypoglycemic agents. The blood sugar control is fair during these 4 years. The fasting sugar has remained in the range of 120 to 140, and he used to be on regular follow-up. There is no history of any eye problems, any symptoms suggestive of neuropathy, autonomic dysfunction, no history of any nocturia or lower tract symptoms. There is no history of hypertension, bronchial asthma, or any other complaint. No history of any previous surgeries in the past or any symptoms suggesting nephritic or nephrotic illness in the past. Personal history, patient is a non-vegetarian by diet, no addictions, normal sleep and appetite, bladder bowel habits normal. Family history, there is no history of diabetes, hypertension in family, no history of any kidney disease in the family.
Anyone else wants any history? Anyone wanting any particular history? Anyone? Any history of recent drug intake?
Sir, not before the illness started.
Nothing before. He was not taking any traditional or otherwise.
No alternative medication.
No alternative medication.
I missed that out.
So based Yeah. So based on your current history and the background history that you have, so what do you think is going on in your mind at this point of time?
Uh, Sir, my patient, a 56-year-old diabetic male with history of fever, fatigue, and rapid progressive renal failure over 1 month. So I've kept a syndromic diagnosis of rapid progressive renal failure in such a patient with
Okay.
when I have a baseline report of normal creatinine around 1 month back.
Why did he get creatinine done at that point of time?
Sir, he was a diabetic. He used to be on regular follow-up.
Okay. And his renal functions prior to this was also normal.
0.9 creatinine,
He remembers this. Okay. Okay. So you said that this is rapidly progressive renal failure. So what do you think could be the possible causes for this rapidly progressive renal failure in
Sir,
this patient?
I've kept three possibilities in my patient. First, I believe it is an interstitial cause since there is history of fever and fatigue. There is no history of swelling. There is preserved urine output and normal blood pressure. So I've kept a possibility of acute interstitial nephritis causing rapid progressive renal failure in this patient. There is history of fever, so there could be an underlying infection which probably got missed by the initial investigation by the doctors.
Okay, that could be one. Maybe an interstitial disease, acute
Yes, sir.
interstitial nephritis,
Right.
maybe
Yes, sir.
an infective
Yes, sir.
etiology. Okay,
Yes,
that's
sir.
one. Anything else?
Second, I've kept a possibility of rapid progressive glomerulonephritis. Sir, the points in favor is that, uh, sir, he has a rapid rise in creatinine. There is fall in hemoglobin.
Mm-hmm.
So that and his age group is on the he's elderly, 56-year-old. So I've kept a possibility of rapid progressive glomerulonephritis in this patient.
Okay.
So third, I've kept a possibility of myeloma nephropathy because there is unexplained renal failure, there is low hemoglobin content, and elderly patient.
An elderly patient whose cause of rapid deterioration of renal function or rapidly progressive renal failure is not evident, at
No.
least clinically. Your possibilities are only based on a clinical kind of thought process. There isn't much in favor of either one of these possibilities, and that's a good possibility of keeping a possibility of a monoclonal gammopathy as an etiology of an unknown progressive renal failure. That's any other possibility?
So I've kept these three possibilities, sir.
Mm-hmm.
Sir, thrombotic microangiopathy could also have been, but with a normal blood pressure, I will not consider thrombotic microangiopathy.
Atypical
I'm
HUS or something like that.
So, but I don't think I've ever seen a patient with a normal blood pressure. That is
With
something which goes again.
atypical HUS. Why would you think blood pressure would be? Blood pressure could be a cause of thrombotic microangiopathy, accelerated hypertension, and that could be cause of. But atypical HUS could occur because of other causes as well. Maybe an can we can we can we switch? Hello, can we switch off all microphones? Puneet, can we switch off everybody's microphone except the
Yes, sir, done,
speaker?
sir. There was one person accidentally on.
Yeah. Please switch off everybody's microphones. Yes, Samir. See, you thought of infection as a cause for interstitial nephritis, but infection could be a cause for atypical HUS as well. There is a drop in his hemoglobin,
Yes,
which
sir.
is dropped from, he knows that it was 12 grams at a month back and is dropped rapidly in about 2 weeks to 3 weeks time to around 6 grams.
6.
So there is
Yes,
a
sir.
rapid deterioration in his hemoglobin. And that, in my mind, can either be because of a loss or there is rapid destruction of his red cells. So in fact, actually, that would be more of a possibility than a glomerular disease.
Glomerular
This,
disease. Right.
when you were presenting this patient, the mind that I was thinking of could be that maybe it's an interstitial disease, which you thought of very rightly. And I think that's something which remains in the mind. I was not very clear about the cause as yet. Infection maybe, but it has to be a hidden kind of an infection, not very overt infection, which is causing an interstitial nephritis. Usually, when you have this kind of an interstitial nephritis related to infection, then it would be more like a pyelonephritis and all that. But he doesn't fit into that kind of illness. So interstitial disease did come to my mind as well, because his urine output remained well. He did not have, and that's one. His urine output remaining okay and not dropping would go against atypical HUS. There, I would have thought of that there would be some drop off in his urine output, and I think that's something which hasn't happened, at least in the history. That's not available. So that would be a point against it. But a drop in hemoglobin, very rapid drop in hemoglobin, would favor a diagnosis of an atypical HUS in this. This would be also a diagnosis which would fit in with a monoclonal gammopathy of unknown origin, where there are non-specific symptoms, rapid deterioration in renal function, some fever, and generalized symptoms, vague symptoms of fatigue and not feeling well and all that, which would be common to many of these progressive renal failures as well, because when you have rapid deterioration in renal function, many of these symptoms may be related to deteriorating renal function, or they may be non-specific symptoms related to either the etiology of this rapidly progressive renal failure. It could be features of atypical HUS, it could be features of an interstitial disease which is developing in this patient, or sometimes as a lower down, I would keep glomerular disease as a cause of this. Could you think of that this is, you wouldn't think of a chronic kidney disease as an underlying etiology and some acute deterioration, because his renal function, at least 1 month documented renal function, was normal. So underlying chronic kidney disease, which is many times hidden, is not likely in this patient.
Sir, but it could have been that he was a proteinuric diabetic nephropathy with a normal creatinine. It could still be CKD, but we know that hemoglobin was normal, and
Yeah,
so less likely.
looks like, but that possibility, especially in a 55, 56 years old person, past history of diabetes for some period of time, although he doesn't have other risk factors, in the sense no family history of diabetic kidney disease, so he doesn't fit in those risk factors. He doesn't have hypertension as an etiology, so is not there. So that makes a possibility of an underlying diabetic kidney disease, where there may be an infection and that has produced rapid deterioration in renal function, but seems less likely. But one should keep that at the background as well. Always, whenever you have a patient with renal disease, a rapid deterioration in renal function and already compromised renal function may be there. But this looks less likely, especially since there is a documented normal serum creatinine of 0.9 about 1 month back. So still there, but not really high on the cards. I think the possibilities high on the cards would be monoclonal gammopathy. I would keep an interstitial disease high on the cards. I would keep definitely an underlying atypical HUS would remain on the card. Atypical, then rapidly progressive glomerulonephritis would be another thing, or some odd features. Usually, again, there you will find some decrement in the urine output in rapidly progressive glomerulonephritis. Usually, these patients become edematous. They have rapid deterioration. Blood pressure may be moderately increased, usually associated with oliguria. Usually, subacute onset of oliguria would be a feature which would favor a diagnosis of a rapidly progressive glomerulonephritis. That's not there, at least in history. You do not have that history of decrease in urine output, increase in the overall. So at the moment, if you were to pick up one of the diagnoses and which you feel would be the diagnosis, likely possibility out of these 4 possibilities now that we have come closer to, what would you think would be your number 1 diagnosis? That's important. And that's important even in the exam, that when you discuss this, you will still have to keep one possibility over the other possibility. So what's your gut feeling? At the moment, there isn't much in the history which favors one or the other, because history is short. It doesn't have a long kind of a history. But what do you think?
Sir, I've thought of an interstitial disease, and as you said, monoclonal gammopathy, it can be part as a cause of interstitial disease.
Okay. Yes, I think I would tend to agree with that kind of a possibility in this patient, that I have an unknown cause of rapidly progressive renal failure here, and monoclonal gammopathy, I've been told, I have always learned, should be kept in mind in a patient where you do not have a very clear-cut cause of, and an interstitial disease, preserved renal, preserved urine output.
Urine output.
Just non-specific symptoms. There are no specific symptoms related to kidney disease, would suggest a rapid deterioration in hemoglobin as well, consistent with a possibility of a monoclonal gammopathy. I think that would be fairly high on the cards as far as clinical suspicion of this patient is concerned. And I think rest of the possibilities of atypical HUS, glomerulonephritis, acute on chronic kidney disease, or an underlying diabetic kidney disease would be less likely on the possibilities. Anyone else has a brighter idea about this patient? Dr. Biswas, can I see your face? Dr. Biswas. Dr. Biswas, can we see you? Can you switch on your video? Dr. Biswas, I think, is probably not there. He's just, Dr. Biswas, yes.
Sir, good evening.
Good evening. Biswasji, do you have any other brighter ideas about this patient, or did you hear the history completely?
No, sir, I just joined in.
Okay, you just
I
joined
missed it.
in. Okay, let's ask somebody else. Anyone else has a brighter idea or anything? Can we switch on everybody's video? I would want videos to be off, on. Dr. Banu Mishra ji. Dr. Mishra?
Yes, sir.
Do you have any other contribution or anything that you feel you would like to keep in this patient? Anyone else has also any brighter ideas or anything that they want to make a comment at this point of time?
No, sir, I would agree with the myeloma being the first.
You agree with our possibilities of anyone else has any other? Doesn't look like that we have any further contribution to it. Samir, let's
Yes, sir.
proceed then. Let's proceed.
Right, sir. Sir, on examination, patient is conscious, cooperative, sitting comfortably in bed with an intracath in the left hand. Vitals, pulse is 78 per minute, normal rate, rhythm, character, no radioradial or radiofemoral delay, all peripheral pulses palpable. The blood pressure was 110 by 80 in left arm supine position. It was 112 by 78 in right arm supine position, 126 by 78 in right leg, and 120 in left by 70 in the left leg. There was pallor present, no icterus cyanosis, clubbing, lymphadenopathy. Pedal edema was present. JVP was not raised. On general physical examination, patient was average build. Hair was dry, grayish color and with androgenic alopecia. Oral hygiene was average, no dental caries. There were no lesion in nose, ear, or throat, no crusting or ulceration in these areas. Nails were brittle in nature, no other skin lesions found. In systemic examination, sir, cardiovascular, respiratory, neurological, they were all normal, sir.
So the physical examination, does it add anything to your possibilities or
Yes, sir.
delete anything? Yes.
Sir, one is normal blood pressure.
Okay.
Second is there is pallor, there is pedal edema.
How severe is the pedal edema?
Sir, it was mild only up till the ankles, pitting,
Okay.
but mild.
Okay.
And
So,
sir, that's it. And no skin lesions and no ear, nose, throat lesions, sir.
okay.
So fundus examination was done. There were no features of diabetic retinopathy or hypertensive retinopathy.
Okay.
And sir, urine routine was done.
Mhm.
Urine showed color was yellow, specific gravity 1.015, pH 6.0, glucose, ketone, bilirubin were nil. Blood, dipstick blood was 3 positive. Protein in dipstick was 2 plus. On microscopy examination, first cells were 15 to 20. RBC is full field. Epithelial cells 1 to 2, no cast. And RBCs, sir, we did RBC. We saw the RBCs on simple microscopy, and they were dysmorphic RBCs.
So what does it tell you now?
Sir, there is edema, there is pallor, there is glomerular hematuria and proteinuria.
So there is some degree of proteinuria. There is RBCs. There were no casts that you said.
No, sir.
You didn't. No casts, but there is
No cast.
There is RBCs, and these RBCs on microscopy look like dysmorphic RBCs, isn't it? That's what
Right,
you
sir.
said. So they
Right,
look
sir.
more like. So from this urine examination, what do you infer?
Sir, it is a more of a glomerular pathology.
So in this
rather than an interstitial.
in this urine routine examination is extremely. Can we switch off everybody? Can we switch off everybody's? Can everybody switch off the audio? Because there's a lot of background noise coming from some place. So Samir, you said that this looks more like. So if you were to now look at the possibilities after examination and the urine routine examination availability, what do you think are the possibilities now that you are thinking of?
Sir, I will keep a possibility of rapid progressive glomerulonephritis as my first option.
And the points in favor are?
Sir, there is pallor, there is edema, there is proteinuria, there is hematuria.
There is microscopic hematuria, and there is RBCs which are dysmorphic on. There is some degree of albuminuria. He has edema, which
Right.
he's on history. He did not give any features suggestive of, but on examination, you find that that's a feature which will favor more. So at this point of time, can you rule out monoclonal gammopathy totally, or
No,
you will
no,
like
sir.
to keep that in the possible background?
Sir, it could still be a possibility.
It
There
could
can
still be a
glomerular
possibility.
injury. Yes.
So one is that you are keeping glomerular injury, glomerular pathology, and it could be a rapidly progressive glomerulonephritis, or it may be still, you are still considering that may be a glomerulonephritis related to monoclonal gammopathy, because that's also known and documented. Okay, so you are keeping up that kind of a possibility. Anyone else adds anything? Anyone wants to add anything specific? But you did not find any evidences of ear, nose, and nose, so that looks to be, at least on clinical examination, it doesn't look like to be microscopic polyangiitis with ANCA kind of disease. So at the moment, at least clinically, there wasn't any clues, but then obviously, you know that many times you may not get clues about the clinical spectrum of microscopic polyangiitis with granulomatosis. So you may not have clues in this, and they may present with renal limited kind of disease, and therefore you may not have other systemic features which may be present in these patients. So how will we proceed now?
Sir, I had one question.
Yes.
Sir, I found normal blood pressure on examination. Is it possible for glomerulonephritis to have normal blood pressure?
Yeah, that may not be present in everybody, and that's the beauty of clinical medicine, that you would commonly see it, but blood pressure may be not a presenting feature in many of these diseases. So your blood pressure can be present in a large majority of these patients, but again, that's the variability that you see in clinical presentations and may not be present in early stages of these diseases. So I think that's still possible, but that's a possibility, which is what will keep the monoclonal gammopathy still in the picture, that this may not be a typical kind of rapidly progressive glomerulonephritis usually associated with autoimmune disorders or with an infective etiology, or with, say, if you were to think of post-streptococcal rapidly progressive glomerulonephritis, that would present much more with increased blood pressure. Autoimmune, say, vasculitis, that again, majority will have blood pressure, moderately increased blood pressure, not a very severe hypertension, but severe hypertension in post-streptococcal glomerulonephritis, acute glomerulonephritis. Yes, that's what would be. But this is very unlike the presentation for that kind of thing. So blood pressure, normal blood pressure might still take you still in the domains of monoclonal gammopathy and still there in the differential diagnosis. Yes. So how will you proceed?
Sir, I will, sir, after examination, I will do routine investigations for the patient.
So what will be your first investigation that you will want to do?
A complete blood count.
Okay.
I would look at the
okay. Yes.
Hemoglobin, the TLC, sorry, MCV, mean corpuscular volume, the platelet count, since atypical HUS was also on the cards initially.
Yes.
Then ESR, if there is any autoimmune pathology, and myeloma also has higher raised ESR, and some peripheral smear to look for fragmented RBCs and schistocytes.
Yes, since I think it's very important when you look at the investigations that you would order, and this is important for exam point of view also, because you have made these 4 or 5 differential diagnoses, and whenever you are looking at the investigations that you look at, you predominantly have to fit in this to either confirm your possibilities, clinical possibilities, or rule out these clinical possibilities. And so looking at hemoglobin and MCV and platelet count, the leukocyte count, because infection has been one of the differential diagnoses, atypical HUS has been one of the possibilities, and monoclonal gammopathy is one of your strong contenders in the differential diagnosis. So you would want to keep these as the investigations by which you will like to rule out or confirm one of these. So I think from that's okay. Do we have anybody who has the information about this? Someone else from?
Sir, I have the reports.
You have the reports? Okay.
Yes,
let's get the reports. What's the hemoglobin?
So just a second. So hemoglobin is 6.5.
Okay.
TLC is 4,800.
Okay.
Platelet is 2.5 lakhs.
Okay.
And sir, ESR is 66.
Okay. Peripheral smear or something?
Peripheral smear. Sir, actually peripheral smear showed normocytic normochronic anemia with few microspirocytes, adequate platelets, and adequate TLC.
Okay. Okay. So this is sort of at least suggests that this is atypical HUS is not a likely possibility, at least normal platelets, peripheral smear is good. Okay. What else? He has severe anemia.
Right,
And
sir.
total leukocyte count is not raised at this point of time, so at least doesn't suggest an overt kind of an infective pathology at this point of time. Okay, what else? So you looked at the hemogram. What else would you do?
Sir, a kidney function test.
Okay, so what do the kidney function tests? You will look for urea creatinine. What is the urea
Sir,
creatinine?
electrolytes.
Electrolytes.
Yes, sir. Urea is 200. Creatinine is 5.6.
Okay.
So sodium 139, potassium 4, chloride 97, uric acid is 10, calcium 7.5, phosphorus 7.
Okay. So what does it suggest to you?
Sir, a normal calcium, I would like to look at the albumin level before I conclude
Okay.
about
Okay.
calcium levels.
Okay.
Sir,
So what's the
and
album?
sir, albumin is 2.9.
Okay. It's on the lower side. So
Yes,
corrected calcium would be?
8.4, 8.5.
So reasonably okay. Not
Yes.
low, maybe mildly on the lower side, but otherwise okay. Yes.
So next, a liver function test.
Okay.
Sir, I'll look at the ALT, AST, alkaline phosphatase, albumin, as I said, and total protein, and
Okay.
look for albumin globulin ratio.
Okay.
Sir, in my patient, the total protein is 5.1, globulin is 2.2, albumin is 2.9, ALT, AST is normal, and total bilirubin 0.4.
So it tells you that this patient has hypoproteinemia and hypoalbuminemia. So what else would you do now? And liver functions
Sir,
are normal.
yes, sir. Sir, then viral markers. Sir, hepatitis B, C, and HIV.
They're all negative.
Yes, sir.
Okay.
So one thing I forgot to add, urine quantification of urine
Yeah.
protein.
In fact, actually, this is the commonest mistake made. Whenever you have a patient in nephrology, I think as a nephrologist, I think you have to give respect to urine analysis. And I think you did a urine examination yourself, which most of the time you will do in the exam as well, or you will be given the urinary findings. So you should, the next investigation that you should be always a quantification of 24 hours urine protein or quantification by a spot urine protein creatinine ratio. Ideally, one of the first urine examination, or at least once, you should have a 24 hours urine collection for estimation of quantification of urinary protein. Do we have that?
Yes, sir. So urine spot urine protein is 103 milligram per deciliter. Creatinine is 53.4 milligram per deciliter. A spot ratio is 1.94.
Okay. And do we have a 24 hours urine also?
No,
Not done.
no, sir.
So it's got about 2 grams of proteinuria. Okay.
Right, sir.
Okay. So what do these investigations tell you till this period of time?
Sir, there is anemia, but no hemolysis.
Okay.
There is renal dysfunction, and there is proteinuria.
Okay. And hypoproteinemia, hypoalbuminemia, hypoproteinemia, hypoalbuminemia. Okay. But his proteinuria, does it surprise you that he's got a proteinuria of about 1.9 grams in a spot urine protein creatinine ratio? You would have expected, with the degree of say hypoproteinemia and albuminemia that this patient has, didn't you expect a much higher degree of?
Albumin, sir, can reflect loss of protein, or even since this patient has been having this illness since 1 month, so maybe malnutrition or could have been a possibility of low albumin.
You mean to say that, see, what's the half-life of albumin?
So 15 days.
Yeah, about 20, 25 days or so, half albumin. So it takes about a month of month of an illness to produce dog. So I would guess that this illness, although he gives you a history of 1 month, with the, if this is the cause, if proteinuria is the cause of his low protein and albumin, then I would think this illness is more than 1 month old. I would not expect a urine proteinuria of 1.9 gram to give him such low proteins and albumin in 1 month's time. So I would have expected that either this illness is of a longer duration and he hasn't known it, or he has not been, he's malnourished and all that. But examination, you didn't tell me that he was really malnourished to that extent that he has had low protein and albumin. See, you see many patients of chronic kidney disease on dialysis who are extremely malnourished, and you look at their total proteins and albumins, they don't change too much. In fact, they are normal. You get surprised that you see severe malnutrition on physical examination and looking at the patient, but their total proteins and albumins are reasonably good. And here you have a patient who otherwise physically at least didn't look to you like a malnourished patient, but has had a low protein and low, and probably it is related to his proteinuria and to renal disease. And I feel that maybe the renal dysfunction itself, the rapidity with which this deterioration has occurred, may have caused a decrease in the degree of proteinuria as the renal function deteriorated. That could be one such reason. Or maybe the urine protein estimate does not provide you. That's one of the fallacies of a spot urine protein creatinine ratio. It may not necessarily reflect the 24 hours urine protein, and you will probably need one estimate of a 24 hours urine protein excretion at some point of time in this patient. That's why, at least when you evaluate patients with kidney disease, with proteinuria especially, then it's important that you should do once a 24 hours urine protein and then use spot protein creatinine ratio as a follow-up monitoring kind of an investigation rather than a total diagnostic evaluation. Okay. So
one possibility, I thought maybe there's underlying diabetic nephropathy with long-standing proteinuria.
We haven't ruled that possibility out. It is there in the picture that he may have an underlying proteinuria related to diabetic nephropathy, type 2 diabetes. This is known that many patients may have proteinuria, but proteinuria related to diabetes is again also reasonably high. Proteinuria of this degree will probably, and then he has RBCs also in the urine. So there has to be some other disease, probably, maybe a glomerular disease. Even in a diabetic, when you have this degree of proteinuria, you have some RBCs in the urine, then you would think of diabetic nephropathy. If you have this degree of proteinuria, then hypertension would again be another feature which is usually common, majority of patients with diabetic nephropathy.
So can we also keep a possibility like he's a diabetic, there might be underlying chronic liver disease which is causing low albumin?
Chronic liver disease because of what?
NASH related liver disease in diabetes.
Yeah, but at least your liver enzymes are normal at this point of time and you do not know. So look odd. I would think that at the moment the evidence is that we have this patient some proteinuria and he's got hypo. So we will have to link at this point of time this degree of hypoproteinemia and hypoalbuminemia to his renal disease. At the moment, that's what it looks like. So we will have to look at that from that perspective. So we can go ahead, proceed.
So now I would like to do autoimmune markers for this patient since I've kept the possibility of RPGN.
Yes.
So, sir, ANA, ANCA, CNP, Anti-Gbm, C3, C4.
Okay.
So these are some of the investigations which I'd like to do for this patient.
Okay. So what did you find?
Sir, in this patient, C3, C4 were normal and C-ANCA, P-ANCA were normal. Anti-GBM, the sample which we sent got hemolyzed, so we sent a repeat sample after 2 days.
So we don't know. But
Yes, sir.
anti-GBM is a less likely possibility in this patient, isn't it? Or you think
Yes, sir.
urine output is preserved?
Preserved.
Usually anti-GBM disease will present with this kind of rapid deterioration in renal function, will present usually with oliguria in this patient. Non-oliguric anti-GBM disease sort of would be very, very uncommon, very, very rare. So I would keep that possibility lower down in the picture, if at all. But I think as an investigative tool, yes, would send for an anti-GBM antibody in this patient. Okay.
Sir, I would like to do an ultrasound of the kidney
Okay.
to check for kidney size, echogenicity, any features of obstructive uropathy, and post-void residue.
In the blood test, I thought now that since you were at the blood
Coagulation
test,
markers.
one is the coagulation markers, the other would be you monoclonal gammopathy was high on your cards on
Yes, sir.
clinical examination. So you missed a serum protein electrophoresis, immunofixation, and serum free light chains. So I would have looked at the urine examination also, looking for any
Light
significant
chains.
Benz-Jones or light chain proteins and all. So I think I would look at in the exam. You have a lot of examiners who are internal medicine, spot on internal medicine, high on it. So they will look at you. If your possibility is high, they will also ask you to whether you looked at the urine benzone protein,
Right.
and they would
Right,
they would have asked you that would you look for benzone protein, and had you done a test for benzone protein. So especially when you have this differential diagnosis high on your clinical differential diagnosis. So I think that's something which I would have wanted you to say.
So we did an SPEP. There was no spike, no M
Okay.
spike, and kappa lambda was also normal. In
Okay.
ratio was in IF.
So many times when we are ruling out monoclonal gammopathy in clinical medicine, we do serum protein electrophoresis. That's what is commonly done. What's the sensitivity of that test?
So around 80-85%.
Yeah, it's about 80% or so. So sensitivity is about 80%. So you will have to add another test, either a serum-free light chains, or you will have to do a serum immunoelectrophoresis or immunofixation, and then or a urinary immunofixation by which you will pick up. And what's the sensitivity of this?
Sir, if we combine all this, then it is around 99%.
Yeah, then if you combine all the three tests, serum-free light chains and urinary immunofixation and the serum protein electrophoresis, then yours becomes about 98% or so. You should be able to pick up or rule out significant monoclonal gammopathy as a cause of your renal dysfunction. So that's this is negative. Serum-free light chains are negative, and the serum protein electrophoresis is negative.
Right, sir.
Okay.
So now imaging wise, we got a CT done. He actually got an ultrasound done from outside. So we did a CT CT scan. Sir, CT abdomen showed bilateral bulky kidneys with increased echogenicities and no features of obstruction.
Okay.
So, sir, then we proceeded.
So what was this bulky kidney in your mind? What do you think this suggests, or this does it give you a clue to diagnosis or something?
Not sure, sir.
Not really. No, the kidneys become bigger. Sometimes acute glomerulonephritis might produce some swelling. In the acute tubular necrosis, also the kidneys might look somewhat on a plain CT. They may look somewhat swollen and bigger. And an infiltrative disorder also would produce something, a swelling in the kidney and all that. So echogenicity is increased, which tells you that there is a renal disease in these kidneys. So very difficult sort of to lay your hands on a particular diagnosis on these imaging, basically. So all of these possibilities could be consistent with this kind of an imaging.
Yes.
Okay, so what will you do now?
So kidney biopsy.
So you obviously, the strongest weapon in the hand of a nephrologist is to do a kidney biopsy, and you did a kidney biopsy in this patient.
Yes, sir.
So what did you find?
Sir, there were multiple sections of HNE and past silver stain, 24 glomeruli seen, none globally sclerosed. 75% of the glomeruli reveal overlying partial circumferential cellular crescents. Several glomeruli reveal fibrinoid tuft necrosis. Viable glomeruli appear unremarkable. Few show discontinuity, rupture of Bowman's capsule enclosing the proliferating extracapillary cells and eliciting lymphohistiocytic response. IFTA was 10% with severe acute tubular injury, scattered hyaline granular casts, and several RBC casts were seen.
Okay, immunofluorescence.
Yes, sir. IF showed diffuse IgG staining for glomerular capillaries. IgA, IgM, C3. C3 was 1 plus, no kappa lambda difference.
Okay.
So, sir, a diagnosis of necrotizing crescentric glomerular nephritis with cellular crescents and DIF showing diffuse IgG staining with severe ATI suggesting anti-GBM disease.
So this was a linear kind of immunofluorescence.
Yes,
I would have wanted you to actually make a photograph of the slide actually for presentation, because that would highlight as to because this disease now, if you are talking of an anti-GBM disease, as we discussed, that this looks to be a very less likely presentation of an anti-GBM disease usually.
yes, sir.
Not seen in this kind of a thing. But
so that is why we actually
said,
didn't send anti-GBM on the first day. We planned it 2 days later.
Yeah, because usually oliguria is a much more remarkable feature of it. But I can tell you that long time back, about 20 years back, when I first joined Apollo Hospital, we had a patient who was picked up as an anti-GBM disease after the biopsy. Actually, we had a patient who had been admitted in pulmonary division, and this patient was working in a factory. There was some blast and some fumes he had inhaled some fumes, and then so he had come with acute sort of pulmonary syndrome and admitted to Apollo Hospital. And some days later, as he was recovering, they found that he had proteinuria and some. Can we switch off all? So much of background. I hope Samir is not in your home. There's a lot of background noise which comes. So this patient had albuminuria and some RBCs in the urine, and they asked us to come and sort of, we looked at the proteinuria. Proteinuria was about 2.8 grams, something like proteinuria in this patient. He was normal urine output, mild swelling, but not much. Blood pressures were good. We did a biopsy because we didn't know what he had. He had microscopic hematuria. His urine output was good. His kidney function was mildly deranged. Creatinine of about 2.2, and he had some proteinuria and RBCs. And we did a biopsy, and we were surprised. We didn't expect it to be anti-GBM disease, but when we went to the biopsy room to see this biopsy, and we were told, the pathologist was extremely excited because this was his first case of anti-GBM disease, and he said this is anti-GBM disease, and we didn't believe him that this was an anti-GBM disease, and this is exactly what that patient had. But then this is not a common presentation of an anti-GBM disease. Usually they are much more dramatic. they're more oliguric, sicker, and more rapid. And this is known. It's not, when you look at the spectrum of anti-GBM disease, then about 10 to 15% of patients might present like what your patient has presented. Majority will present as an oliguric, highly crescentic, and with a very rapid deterioration of renal function. This patient has a rapid deterioration of renal function. In 1 month's time, his kidney function, but his urine output surprisingly has remained in good state. So how is he done so far, Samir?
Sir, we started him on plasmapheresis.
Okay.
And we gave him pulse steroids and pulse cyclophosphamide. And we started him on plasmapheresis. We have done daily plasmapheresis for 7 days.
Okay.
His creatinine at the time we started plasmapheresis was 5.6. And so now it's been 7-8 days. He's attained end stage renal disease. His creatinine is in the range of 7.58. There is cross anasarca. But his hemoglobin has stabilized. We haven't given him any transfusion. His hemoglobin has settled at around 7.1, but kidney function hasn't recovered.
Did you look at his lungs, CT scan, lungs?
So we got a CT chest done, and there were fibroatelectatic infiltrates in bilateral lower zones, but no specific features of lung hemorrhage. We did not do a bronchoscopy.
Yeah, I'm surprised as to why did he drop his hemoglobin so rapidly. One of the reasons in this disease, because this disease we didn't consider clinically, would have been a pulmonary hemorrhage, because that's the kind of a patient who would. But then usually they would present with some pulmonary symptoms. He didn't have any of those, at least.
So he had breathlessness in the later part of the presentation, but it wasn't severe enough for a hemoglobin level to fall by 6 gram%.
And the CT did not show anything suggestive of a pulmonary hemorrhage.
No, sir.
Yeah, that's somewhat odd. Maybe, see, sometimes they have a slow kind of, and you require a bronchoscopy to look at hemosiderin in the biopsies, and that's what might happen in some of these patients. A slow kind of an hemorrhage, which many times may not produce. You will have that kind of a picture in some patients. And we have done bronchoscopies in some of these patients, and many times the pulmonologist says that there isn't an overt hemorrhage, but he's taken a ball, and ball shows hemosiderin-laden macrophages and other things. And then you find that that was probably evidence of a chronic hemorrhage which has occurred in these patients. Sometimes these patients might present with pulmonary hemorrhage, and renal disease precedes, follows it. The first symptom may be a pulmonary kind of a symptom. So how would you treat this patient? You said that you gave him plasmapheresis. So plasmapheresis, you gave 7 of them.
Yes, sir.
How long would you continue to give plasmapheresis?
So it is said around 10 to 14 sessions, but ideally we should give till the anti-GBM titer is non-detectable.
Yeah, but you haven't even had the first titer as yet, because the first
we
sample
sent a
was,
titer later.
Yeah, I
Yeah,
know.
we sent a titer later on. It was 1:10 in IF by IF method.
Okay. And so you haven't seen any drop, or we don't know, you don't know yet?
So we have sent the second sample. It would be available tomorrow or day after.
Okay, but his renal function hasn't shown any decline, has no change. And what has happened to his urine output? Urine output is...
Sir, it has reduced now. Urine output has reduced. He is in gross anasarca. There is swelling, massive swelling. He is on diet or infusion now for urine, increasing urine.
You not started dialysis yet on him?
So we are planning to do it in a day.
You're planning to do a dialysis on him. And how long has he received cyclophosphamide?
So we gave him 1 pulse before 24 hours before starting plasmapheresis.
Okay.
500 mg.
Okay. So how would you treat anti-GBM disease?
Sir, sir, anti-GBM disease, it is a disease where antibodies, IgG1 antibodies are formed against the GBM. So we need to stop the production of newer antibodies, and already the antibodies which are present in the body need to be removed. So a pulse dose of steroids, and KDIGO recommends oral cyclophosphamide along with plasmapheresis.
Usually, do you give immunosuppressive treatment to reduce further production of anti-GBM antibodies? No, anti-GBM antibody is a one single hit disease. Usually happens either because of a viral illness, that there is a production of an antibody which either cross-reacts or it induces an activation of the anti-GBM antibody, and it's a one-hit kind of a thing. Usually, once the antibodies are formed, it causes sudden damage to the glomerular basement membrane and to the glomeruli, and or into the lungs, because they share the same kind of an antigen. And yeah, and that's what. So your aim of giving immunosuppressive therapy, plasmapheresis is obviously done to remove the antibodies which are present, because that otherwise will cause further damage, either if not in the kidney, if kidneys have been fairly damaged, then this antibody could cause damage in the lungs. So you would want the antibodies to go down, and that's why you do plasmapheresis, to remove these antibodies as much as you could. But you give immunosuppressive therapy basically to see whether the kind of damage which has occurred in the lungs as well as in the kidneys, that you can reduce inflammation and produce some kind of a repair, if that is possible. Usually antibodies will decrease on its own now over a period of time, because there is a sort of a linear kind of decremental, or these will be taken up by the process of macrophage system, and then the elimination of these antibodies occurs through the body. But otherwise, usually there isn't a method by which you can sort of reduce the formation of these antibodies by giving immunosuppressive agents and all that. I don't think they have an impact on that. So these antibodies will go away in what period of time usually? So
if untreated, then it goes by around 6 months to 2 years.
Yeah, it may take some time for the normal natural elimination of these antibodies, depending on also what the titer is. If the titers of these antibodies are very high, then it might take long time for this. But in some people, the titers may not be that high, and the titers might go down quickly and the antibody might disappear. Usually in 3-6 months, or maybe sometimes a longer duration of time. Now, this patient, at the moment, you seem to have sort of considered that he is unlikely to respond to therapy, isn't it?
Yes, sir.
This patient, you declare that he's gone to end-stage kidney disease and therefore unlikely to respond, and you're no longer going to give him further plasmapheresis, and you may not, depending on if the antibodies are not very high, and you may stop immunosuppression also. In a patient who has reached the kind of an end of the road as far as recovery of renal function is concerned, then usually there's no point in continuing to give extra amounts of immunosuppressive drugs, because that causes more harm than doing any good. And you need to put these patients on dialysis. Now, if this patient tells you that you will tell him that this patient unlikely to recover, what about transplantation?
Sir, once the anti-GBM titer is reduced to 0, they are undetectable. We wait for about 6 months to plan for a renal transplant, according to the KDIGO guide.
Yeah, you should, once the antibodies go down, then you may wait from 3 to 6 months. KDIGO says 6 months, I agree. But we see in India, normally patients don't want to wait if the antibodies have gone down. And we have transplanted some patients even earlier than 6 months. We haven't waited for 6 months. We transplanted them at 3 months, somebody at 4 months. After the titers have gone down or they are undetectable, and 2 titers have remained undetected in between, say, 1 month or 2 months, and then we go ahead and do a transplant in these patients. So we haven't waited always for 6 months or more, but after the antibodies have become negative, we do another antibody test maybe a month or 2 later, and then if they are negative again, then we would go ahead and transplant such patients. What's the likely outcome of such transplants?
Sir, recurrence of anti-GBM is very rare post-transplant, so not much problem with the outcome.
Yeah, as I said, that this is a one-hit disease. It's not like an autoimmune disorder where there may be recurrences and all that, or because those disorders don't go away. Anti-GBM is a single-hit disease. It occurs probably, it occurs. Tell me, what is the cause of this? Etiology, how does it happen?
Sir, there have been theories of hydrocarbon exposure, smokers having pulmonary hemorrhage, lung infections. Then, sir, that is all I know.
Mm-hmm. So what happens actually with these hydrocarbons or lung hemorrhage or a viral illness? So the disease was first described when?
By Goodpasture.
Goodpasture syndrome. So Goodpasture syndrome is what? It happened when?
I'm not sure.
Not sure. Anyone? 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 When did it happen? First described in? (2019), 1919, about 100 years back. This was after the flu pandemic we had. So that time, after the pandemic, the Spanish flu pandemic, then Goodpasture described there were patients who had pulmonary disease and so viral pulmonary pneumonitis or something. So that is where they found that there were patients who had renal disease following this pulmonary hemorrhage, and that's where Goodpasture described this Goodpasture syndrome. It was elucidated much later. That time they didn't know that this was an antibody to the glomerular basement membrane, and they found that this was Goodpasture syndrome was pulmonary hemorrhage along with kidney disease in these patients, and that's how they called pulmonary renal syndrome. And the important cause of pulmonary renal syndrome is anti-GBM disease. What are the other causes of pulmonary renal syndrome, Sameer?
Sir, there can be autoimmune and non-autoimmune causes. In autoimmune causes, MPO or GPA, Behçet's, and IgA vasculitis can be causes. In non-autoimmune, features of acute cardiorenal syndrome, congestive heart failure with pulmonary edema. There can be pneumonia with AKI, sepsis. AKI, these can be.
In the autoimmune one, systemic lupus erythematosus. You forgot.
Yes, sir.
Yeah,
Right,
that's an important cause. And anti-GBM disease would be again another cause of pulmonary renal syndrome, and obviously non-immune hypertension and radiation nephritis. Sometimes, if the radiation has occurred in the pulmonary area, then sometimes you can get that kind of syndrome as well. So any other time you would see this anti-GBM disease?
Sir, Alport syndromes when they have undergone kidney transplant, post-transplant, they can have anti-GBM disease.
Why would they develop anti-GBM disease?
Sir, actually, there is a defect in COL4A5 gene So alpha 5 non-collagenous part is absent in the native patients. So they are not tolerant to this antigen, and when they are transplanted with a new kidney, then the patient is exposed to this antigen and they can develop antibodies and precipitate as anti-GBM.
But the antibodies they present are actually more like what kind of, not alpha 5, is alpha 3.
So the anti-GBM is alpha 3, Alport is alpha 5.
Yeah, I know. Alport is alpha 5, but you have a disease exactly like anti-GBM disease, not necessarily alpha 5. So why would they develop anti-GBM disease? I haven't. If they don't have alpha 5 call A4 gene, why would they develop?
Sir, these patients never had this antigen in their body, so they were never immune tolerant to this antigen.
Oh,
so they treat it as a foreign antigen.
Yes, they have this antigen. But what happens is that how are these antigens sort of how are they structurally sort of fixed? How do they relate structurally? Alpha 3, alpha 4, alpha 5, and alpha 1, and how do they look structurally? Intertwined.
Alpha 3, 4, 5 form a triple helix structure.
Yeah, they form a triple helix. And so what happens is that normally alpha 3 is hidden in the context of the alpha 5. So usually they're not exposed in that kind of a fashion. And when the alpha 5 is not available, so you have actually even in this anti-GBM and anti-3 antibodies against the call3, because this antigen somehow is not exposed in this, and therefore they will present with antibodies against this antigen as well. So you may have alpha 3 antibodies as well as antibodies against the alpha 5 as well in these, because this antigen usually is presented in such a fashion that it's usually intertwined with each other and is not expressed when alpha 5 is absent in Alport syndrome, and therefore you can present with an typical anti-GBM disease. How common are anti-GBM antibodies in Alport syndrome?
So post-transplant, around 1% incidence has been seen.
And anti-GBM disease will develop in what percentage?
So post-transplant?
Yes.
Sir, it is rare.
Yeah, actually antibodies may be present in a larger percentage of people, but anti-GBM disease occurs in less than 1% of people. Anti-GBM antibodies may be present in 10-15% of people also in Alport syndrome, but anti-GBM disease doesn't develop in majority of these patients. So they so if you have a combined anti-GBM and ANCA, how common is that?
Sir, around 10 to 15% patients have positivity for both anti-GBM and ANCA.
And how will they behave?
Sir, they have better prognosis as compared to either disease alone. But actually, sir, there have been two studies. One study has shown a good prognosis. The other study has shown a bad prognosis. So,
yeah, there is a conflicting literature on this. And initially, it was believed that they behave more like an anti-ANCA. They behave more like ANCA disease and have a better prognosis than single anti-GBM disease as such. But the other study has shown that the prognosis may not be as good as once it was believed to be. So there is a conflicting results in the literature as such. But by and large, they may behave like an ANCA disease rather than, so somewhat better prognosis by and large. In our experience also, we have had about 6 or 7 patients who have had combined disease and usually have done better than anti-GBM disease. But then obviously there is variability in anti-GBM disease, although this patient of yours that you saw today, one would have at least from clinical presentation, would have thought that this would be a disease which might respond to therapy, because it didn't present with severe oliguria, and although biopsy did suggest that there was fairly high degree of crescents and the Bowman's capsule was ruptured, as well as there was I think fibrinoid necrosis as well in this biopsy. So this biopsy was severe, although clinical presentation didn't look like as severe as was the biopsy finding. So one would have thought that this, if this is an anti-Gbm disease, one would think that this might respond to treatment and might have a shade better. What percentage of people will respond to treatment?
Sir, in anti-GBM, there has been a study done by Homer Smith Hospital over 25 years in around 85 patients. So they found that
they probably have had the largest kind of database on anti-GBM disease is the Hammersmith Hospital. They at least for initial years, till this disease was not as well known to clinicians, Hammersmith Hospital seemed to have a fairly good conglomeration of the data of anti-GBM disease. And what was the evidence there?
Sir, they showed that if at the time of starting treatment, if the creatinine was less than 5, then the renal remission at 1 year was around 95%. If the starting creatinine was in the range of 5 and 6, the renal remission was around 60 to 80% at 1 year. But if the patient was dialysis dependent at the start of treatment, renal survival was around 8% at 1 year.
Yes, that's true. There is a question of triple, yes, a trimer. That's no, I was looking at the question box and I was thinking that if there were questions, there were answers. Some of the answers that we were talking about, and 1919, the description of a Goodpatcher syndrome, triple helical trimer was the other one. Then I don't know, there's somebody who says these agents, I don't know which agents is he talking about. I think the agent, viral infections as well as probably fumes, the hydrocarbon fumes. I think that's what he may be talking about. Is there anyone else who has a question or something they want to ask Sameer? Sameer, it was an interesting patient, very interesting. I think the presentation and all thing. I think you did a good job of keeping the possibilities, and I think, but it turned out to be a typical rapidly progressive glomerulonephritis, and the urine examination. It tells you that if you actually look at the history and the other presentations, but when you come to urine examination, physical examination did put you in favor of glomerular disease. Urine examination almost confirmed it, that there was microscopic hematuria. And can we switch off the audios? Can we switch off audio? Then it again highlights that urine examination, the physical examination, and the history should be able to give you a reasonable clues towards the diagnosis if you analyze it reasonably well. And in this patient, I think Sameer, after the examination and the urine routine, was reasonably certain that this looks like to be a rapidly progressive glomerulonephritis, and the causes for, although it didn't look like an anti-GBM disease, at least on clinical grounds, but obviously as a rapidly progressive glomerulonephritis, the causes could have been either an immune mediated disease or an immune anti-GBM kind of thing or an immune complex mediated disease, or it could be a post-immune kind of an illness, but it turned out to be an anti-GBM disease on examination, and kidney biopsy is usually extremely helpful in differentiating all these conditions. But I think overall, a reasonably well discussed patient, Sameer. So I must compliment you for a good presentation and overall well done.
Thank you, sir.
Any other questions or comments would be good. Anyone having any comments, questions? You should learn to ask questions. I think somehow not being able to. Mayur, any question?
No.
No, Mayur. How many of you are appearing in the exam? How many people are there going for the exams? Sameer, any likely date?
Sir, you must be knowing better.
I must be knowing it. No, I don't know it. I really don't know it. So how many people are appearing? Do we know roughly? From Delhi, NCR would be yours. Yes, Mohit. Mohit, you want to say something? Mohit.
Sir, I was just saying that we are appearing for exam.
Yeah, I know. So I was wondering how many? 15, 10, 12?
Sir, around 20, I guess. 15, some
About
15,
15, 15 to 18 boys and girls from NCR. How was the theory? What's your general feel on theory? Good, bad?
Sir, good.
It was good. Overall. Expected questions or unexpected?
Sir, more of expected,
More of
less
expected.
of unexpected.
Less of unexpected. सौरभ जी क्या बात है? सौरभ जी स्माइल कर रहे हैं सिर्फ. चलिए जी, if we have anyone has anything to say or anything. So some of you were not there when we started that your next lecture will be by Dr. Sakhuja again, and he wanted to discuss progression of chronic kidney disease. So he wanted one of you to present that case, and I hope one of you has prepared that. And then you will have a nuclear medicine lecture by Dr. Anish Bhattacharya, and then we will have one lecture as per your wishes on hemodialysis, and one lecture on radiology for the nephrologist. So I think that should take care of your wishes. And then if there are anything else that you want, I think we can do that also. And then we will otherwise start with the regular program as we do otherwise.
Sir, could you discuss some basics about urine examination or estimation in brief?
Okay. We could take a lecture on urine examination or urine for examination for the nephrologist. Yes, we could talk about it. Okay. Chaliye ji, we'll do that also, maybe in one of the lectures. Okay. Okay then. Thank you very much. Thank you, Sameer. All the best.
Thank you, sir.
Bye-bye. Bye-bye.
Thank you, sir.
Thank you so much, sir. Thank you.
Okay.